So this is going to be a demonstration of the secondary survey in trauma. Bear in mind that you might not get onto a secondary survey with some of your patients, and this should not delay time on scene. You should really be thinking about doing this secondary survey en route to hospital. So initially we are going to start with the airway, and we're going to inspect that airway and make sure that the patient is still tolerating and maintaining it, the OPA, and there's still no debris, vomit or blood within that airway. We're then going to assess the head, looking for any deformities, swelling, bleeding, lacerations. Everything seems intact at the moment. We're now moving on to the ears, and we're checking for CSF and blood. As well as that, we're looking to see if there's any coming out the nose. I'm going to palpate round about the orbits of the eyes, making sure everything's intact. Moving down onto the mandible, making sure it's intact as well. I'm going to inspect the pupils, and I'm going to think about another GCS at this moment in time. Moving down, I'm looking for jugular vein distension on the neck. I'm looking for tracheal deviation. Any abnormalities. I'm going to check the back of the neck for stepping, which would suggest a C-spine injury. And if we haven't already applied it, then we're going to apply a cervical collar. Moving down onto the chest, we're going to do a full examination of the chest. We're going to get a breathing rate over the minute. And that appears adequate. We're also checking rate, rhythm and depth of breathing as well. We can consider putting on our SpO2, getting our SATs, and I'm also going to do my IPAP. So again, inspecting the chest, making sure there are no abnormalities, no discoloration, penetrating wounds, trauma, anything like that, flail segments, surgical emphysema as well. So everything looks intact, skin colour just looks a bit pale. I'm now going to palpate the chest, looking for equal rise and fall, and again, palpate, and the bases, palpate. Cool. Now going to auscultate, checking the apex, mid-axilla, base, and base. Now going to percuss. Normal resonance, normal resonance, normal resonance, normal resonance, normal, and normal. Then going to consider moving on to C. Again, cap refill, thinking about putting our jacket on, holding for 5, let off, cap refill is delayed. Do we get radial pulses? We can check rate, rhythm and volume. If we don't get radial pulses, we're then going to move up onto our brachial sites. Going to check skin colour, temp, moisture, pale, cool to the touch and dry. You can consider a blood pressure. And I'm thinking about a central cap refill, and I'm doing my 4-lead ECG and my 12-lead ECG. As I move down, again, I'm going to inspect the abdomen, looking for any further distension, bruising, mottling. Again, checking for pulsating masses, and then I can gently repeat my palpation techniques. All the while looking at the patient's face for any grimacing. Abdomen seems soft and non-tender. then going to come down and expose iliac crests, still making sure if they're aligned. We could consider putting on a pelvic binder if we haven't already applied one. And again, we're checking for any incontinence, priapisms or bleeding. Moving down onto the femurs and the tib and fib, again considering decap PHTLS. Do we have all limbs aligned? Do we have pedal pulses distal to the site of injury? Thinking about coming down the arms again, inspecting the arms, making sure they're all intact and all in alignment and there's no deformity. Going to consider a BM again, if I haven't already taken one in my primary, and a temperature. If you haven't already done it, we're going to do a pre-alert to the hospital using a pre-alert card, and when you get to the hospital you're going to use an at-missed handover.